So good morning, everyone. So first, just want to say thank you for all coming in. I know it's definitely not easy to get in, especially for those affected or for those living with these conditions. So really appreciate you coming in for this talk today. Really appreciate also the folks coming in from afar. So whether it be somewhere in Michigan, somewhere you had to drive, even from Columbus, Ohio, home of a team we won't talk about today. Flew in, whether it be from Albany or came in even from New Jersey. So it was great to meet a lot of people from all over today. So some of you may know me as Dr. Spears, Chauncey, or not know me at all. Just for those who don't know me, I've been here at the University of Michigan in Ann Arbor now since 2018. And when I got here, one piece was missing, and that was we did not have at the time an atypical Parkinson's clinic. So being a Parkinson's and movement specialist and seeing that need, in 2019, I started our Atypical Parkinson's Disorders Clinic. And since that time, I've been just very fortunate to be able to recruit, see patients, and establish ourselves as a CurePSP Center of Care and also a Mission MSA Center of Excellence. So it's been just a lovely time there in Brighton, Michigan, which is about 30 minutes north of Ann Arbor, about 45 minutes west from here on a good traffic day. But still there being at the University of Michigan. So today I'm going to give a talk that I'm calling Words to Live By. This talk is largely going to be focused on the things that I tell my patients who are met with PSP and corticobasal, but many of these words are also going to apply to those affected by MSA. These words are not just for patients. In fact, I would say that many of these words are probably even more appropriate for the good folks in the room, our care partners, our caregivers. So, as they say, tell all your friends, take these words. Good. Perfect. So, the first set of words, as a University of Michigan employee, I'm contracted to say, go blue. Yeah, thank you. So just kidding. So the words to live by that I'm going to review today are these three. So they are behave, tolerate, and be merry. So what do I mean by behave? First, I mean this in the nicest way possible. For those who have or who had loved ones affected by PSP or corticobasal, you may have noticed that the reach of their illness is not limited to just troubles with balance, falls, how your limbs move, how your eyes move. If you've noticed that you or your loved one's behavior has changed, you're not alone. Approximately 2 out of 3 patients affected by PSP will have changes in their behavior. And it's important to know that these are changes in the brain of the person with PSP and not simply stubbornness or purposeful. Imagine that each one of us has a part of our brain that's the gas, the go, go, go part. And we also have a brake, or the no, no, no part. In other words, we all have that devil and angel, except for it's not on our shoulders, it's in the front part of our brain, a part of our brain affected by PSP and oftentimes also affected by corticobasal. So knowing this, it's not uncommon to see or pick up signs such as apathy, amotivation, indifference. Sometimes I use the term gumption, being a simple person from West Virginia, where there's just a lack of that go, 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 or too much no, no, no. And that's inherent. That's part of the disease itself. Again, not something that person's intentionally doing, not stubbornness at all. It may seem like the person with PSP is withdrawn or that they may not have that gumption, but that, at the end of the day, is because those parts of the brains aren't firing off like they should. On the other side of the coin, we have impulsivity and disinhibition. So, in other words, folks with PSP can come off as being a little bit mischievous or not listening or have a tendency to go get themselves in trouble from time to time. And again, that's something that can be inherent to the disease, and it's very important for all of us to know that. We see that similarly, but slightly less in corticobasal, and we see that much less commonly in MSA, but some may very well reflect on some of those words. I might have got ahead of myself. Yeah, so for someone who grew up with this character, this is Dennis the Menace, it can feel that way sometimes, right? Some of the most striking examples that I see in my clinic is really when someone is trying to do a little bit too much at a time, namely walking and any other thing. For instance, walking upstairs with a full basket of laundry. I heard that one before. It didn't end well. Carrying things from the car, essentially trying to do too many things at one time and then thwop. We have a fall. I often reflect on this and remind myself and my patients that some have been multitasking, most really have been multitasking for 60, 70, 80 years. Usually I look at the chart and I say, well, how old are you? Subtract 1 year for that, because we all probably started walking when we were about 1. That's how many years we've been multitasking, and now we're asking you to single task, to don't do that anymore. This simple phrase brings focus on that really important thing, is that our brain is powerful, but when we have the weight of these diseases, multitasking may just not be in the cards. We have to reflect and sometimes say to ourselves that when we walk, when we talk, we talk. Very important, very powerful things that sometimes we have to focus as a single task in PSP and corticobasal. That brings me to my next word, which is tolerate. This is as much a reflection on how challenging it can be to change behaviors, especially in the face of these disorders, as well as the general frustrations that anyone would respectfully have when met with such difficulties. So persons affected by these conditions, we ask, well, that you put up with us. You put up with us when we tell you to don't do too many things at once. We ask that you put up with us when we say, don't eat too fast. That's commonly from our speech-language pathologist. We're having troubles with swallowing. Where's their walker? Use that walker. Put on your pants. Tolerate us. I know it. So I know at the end of the day it can seem like it takes a village. And this is very common language. Mary Meager, who runs our Michigan Atypical Parkinson's Support Group, we share in this. And when I think about it takes a village, I often think of my wife, who is from Amish country, Ohio. And I think of how a community of Amish can build an entire barn or raise an entire barn in the matter of hours, if not just a few days. And that's where this comes into play, this theme of teamwork. So more likely than not, your local CurePSP Center of Care or Mission Center of Excellence is going to be a place where you can access a lot of resources. Sometimes at a single center, sometimes across medical campus, or sometimes contracted out. And so at the University of Michigan, I have the true pleasure of working alongside some pretty great people. On the left here is our social worker, Kelly. So if you're a patient of mine, you may not have seen Kelly, but she is the one who gives a call and talks, usually a couple weeks after the diagnosis or when in need. And on the right here is my nurse care coordinator, Kathy Bennett, who's been a neurology nurse for longer than I've been alive. That either speaks for how young I am or how long she's been doing this. But these are the good people at the University of Michigan who help us, in addition to MAs or medical assistants who know how to help fight the good fight for prescriptions, walkers, anything that we need. Help me with that, what can seem like an endless mountain of painstaking but very necessary paperwork. Where our small group of experts can do a lot, we do lean on others at times as well. So those others could include the good folks like John Stoffel with urology, who will be speaking here today. A lot of you may have seen a urologist, as bladder dysfunction, urological troubles are pretty common across the whole landscape of atypical Parkinson's disorders. We also lean on, and you've probably seen if you carry one of these diagnoses, a physical therapist, an occupational therapist, maybe a speech-language pathologist, someone who helps us not just with speech, language, dysarthria or speaking, swallowing, and also communication. And so I go beyond that term speech therapist. I know some may not like that term, but these are our speech-language pathologists who are really pivotal and part of this village. This doesn't include all the other countless folks, so care partners, caregivers, those in the community, those directing the atypical Parkinson's support groups, wherever you may be, the folks who are helping out with home care nursing, home care aides, palliative care, and even hospice care when needed. All those folks are part of that village, and as Mary Meager very well knows, it takes a village, and we are all the village people. And as you can imagine, this word tolerate, it applies both to the person and the care partner. So there are going to be tough days, and your doctor may not always have a great solution on those days. There are going to be things that you wished you could do, and trust me, your doctor wished you could do too. And those things, or at those times, I simply ask to give yourself some grace. Know that it is okay to accept help. It's okay to take a break, utilize respite care. If you're a wife or a spouse of somebody, go out. Get your nails done, hair done. Go for that walk. Okay? Catch up with friends or family, or utilize services such as the CurePSP Quality of Life Respite Grant Program, which I know probably just closed out one quarter and is going to be opening the next quarter of applications soon. While it may be cliche, it's true. As a care partner, you need to take care of yourself in order to be the best care partner for others. Another thing that's very, very important is to find humor. Find humor when you can. Crack that joke. Showcase that personality. Don't be afraid to meet up with friends or family or grandkids, especially those grandkids, because they're probably pretty hilarious to watch and they inject us with energy. And this all leads to my last word: be merry. So now I used to say eat, drink, and be merry. But I think that some have taken liberties with the drinking part, so I've shortened this out a little bit. This be merry part's not always an easy feat, but our time on this great earth is limited. And if I had to say probably well over 100 times, and I don't care if it's typical Parkinson's disease or atypical Parkinson's disease, if you can, get out and do the things you want to do. Oh, you want to go on that cruise to Alaska? Do it. Just maybe not hang over the railings like they did in Titanic. Winter in Florida? I'm not sure why you'd want to escape the frigid tundra of Michigan in the months of January and February, but sure, go for it. If there's something that you want to do and you're able to do it, do it. Do those things on your bucket list as early in the disease as possible, as there may come a time when you're not able to do them. If you do those things and knock those things off your bucket list and you've done all of them, add more. It always brings me joy when I hear that one of my patients does something. And until we have that magic bullet to slow, stop, or reverse these conditions, we're in a position where treating the symptoms or more so treating the patient, focusing on that quality of life should be where we focus. Now, traveling with PSP and corticobasal MSA, that's not always easy. But I loved it when I saw a blog post by none other than CurePSP's Courtney Malberg on traveling with these conditions. As they allude to, planning can be of utmost importance. It would bring me nothing but tremendous joy if I hear that honk of the horn and see a golf cart at Detroit Metro Airport whizzing by me with one of my patients on the back of it. So let yourself get that assistance. Give yourself that grace. Allow yourself to get that help. Have your doctor write a letter if you forecast any troubles. If there's any question whether you're walking, your speech could be misconstrued as you have in maybe one too many, have your doctor write a letter so that they know it's okay. And as also they allude to in Courtney's post, always know where the next bathroom is. Ultimately, it's extremely important for you to prioritize your quality of life. Even early on in the condition, have those talks with friends and family. What means the most to you? What would you do when the rubber hits the road and we're at a real tough point in this disease? So you want to prioritize that quality of life. Define what means the most to you. Have those tough discussions early because they're tougher later on, or tougher when our arm is twisted and we have to make those. And we're talking about things like advanced care planning, living wills, what we would want done in those really tough times, or whoever power of attorney is. And wouldn't you know it, the good folk at CurePSP have thought about this. And they have great information on their website for the nuances of how to navigate it. So remember, these three main words to live by behave, tolerate, and be merry. So I just want to thank you all again for making the trip in, coming in. Thank especially caregivers, care partners, the good folks at CurePSP, and I know I saw Mission MSA out there as well, giving us a lot of information, giving us something to lean on, and really helping us out with this mission to be better. So I just want to say thank you all and take some questions. Oh, and yeah, raise your hand if you have a question. Yeah, so the question was, how did I get into the field focusing on these conditions? And so now I'm not tied to this. I'm going to maybe take this. No, I'm not. I'm going to stand right here. Yeah, so a couple reasons. So if I was being quick and joking, I like coffee. So I like how the brain works and always like that science of it. Always like putting that into words that patients can understand. And I like sleep and I like coffee. And so being an outpatient specialist, seeing people move led me down the Parkinson's route. And when it comes to these conditions, PSP, corticobasal, MSA, they're a challenge. I think a lot of folks in this room have probably heard maybe multiple diagnoses before getting to the one that you eventually settled on. Maybe you've heard the diagnosis of Parkinson's well before a diagnosis of PSP, corticobasal, or MSA. And so I was up for that challenge. I'm also very efficient, and I like to get things done. And the number of things any one person with these conditions needs to squeeze into a 30-minute or 45-minute or 60-minute visit is a lot. And it's not always limited to something that you have a prescription for. And so that's something that I always gravitated towards, trying to be efficient, seeing that this patient population, those with these conditions, need that. And it was just the shoe fit.
Will the University of Michigan be recruiting for the new platform?
Yeah, no, I feel like we'll slip you the $5 for bringing that question up here in just a minute. But yeah, no, we are one of the institutions who will be part of that PTP platform. A couple of the institutions, University of California, San Francisco, Mass General, definitely the main sites. But we've already started that process and going through the paperwork to become one of those sites for the PTP, that clinical trial platform. So really looking forward to becoming a part of that.
Biomarkers. How close are you to finding a biomarker or biomarkers?
Yeah, so Christoph probably could answer that one a little bit better than me. But getting closer is probably a good way to answer that. And so especially with things like we're seeing across Alzheimer's and Parkinson's, things that are done in those fields really can also positively impact those of PSP, corticobasal. So we're finding markers to identify those early. In Parkinson's disease world, within the last year, got an announcement that both spinal fluid, we can find the Parkinson's protein, and also skin biopsy, of all places. So we don't have the skin biopsy yet, but looking at different type of fluids, looking at the spinal fluid, even kind of extracting these proteins from the blood, and the specific proteins for PSP or corticobasal, these are things that are all continue to advance. And so when I go to the big meetings, when I hear folks like Christoph and others speak, I know we're heading in a direction, and it's a positive direction. I just don't have those tests right yet, the special tau scans for these conditions. But MSA, on the other hand, that one has benefited, especially from the skin biopsy. So chipping away at the iceberg.
How many MSA patients do you see versus other diseases?
How many MSA patients do I see versus other diseases? And it's it's probably not fair for me, because I direct the atypical, I directed the MSA clinic at the University of Michigan. I have one half, so really about one half day a week, every week, where I see patients specifically with PSP, corticobasal, and MSA. And so that actually is 1/4 of all the patients I see, and those patients also sneak into my other clinics as well. So for MSA, I see MSA every week, whether it be in the clinic or with clinical trials that we're doing. But that's probably a little bit more than most neurologists.
How do you?
Oh,
Hi.
oh, fire away, Jessica. We have one more
Is that
question up here, though, too.
Oh, no, if there's another question, then
Oh.
it should, yep, wait.
As a CBD patient, I always hear, I'm very pleased to go to Frederick Hospital in Wisconsin, and I always hear that it's just very few of us around the world. And there's no treatment. My doctor tries to help with some suggestions. But I was also, in my body, I was given the gift of developing all the secondary effects of any medication. So I'm free of medication, so I have to leave the CBD 100%. What do you suggest to your CBD patients?
Yeah, and so it depends. So I always say that at the end of the day, you're right, especially in that we don't have a cure right now for these conditions. But we do have treatments. And sometimes those treatments are medications, but that, as you said, they don't agree with everybody. Those medications are very specific to what symptoms, what we're approaching in it. So probably most of the folks affected in this room have tried carbidopa, levodopa, or Sinemet to see if that works, help slowness, stiffness, or even a little bit of tremor. Trying things like baclofen for spasticity, trying medications for urinary challenges, or even medications over the counter or prescribed for constipation. So we always have a treatment, whether it be in the form of medication, whether it be in the form of counseling, whether it be in the form of good PT/OT, or just good advice on how do we make your life as best as we can, despite the challenges you're facing with your condition. So I don't have a broad swath for all patients with corticobasal on what I tell them. It really is very specific to that person. So getting to know them, getting to know how that condition affects them, so how we can approach it together. Sometimes with medication, sometimes with therapy, sometimes just with advice is how I go about it. Oh.
Just wanted to add something to Jessica and I. We need a training with a microphone. It's not a now solution and answer to your question. It's more what we're trying to do. So as many of you know, the protein involved, or that could be causal or part of the reason that people have CBD and PSP is the same protein, right? It's a tau protein. And so for the FDA and other agencies, usually they want a very homogeneous group of people with a given disease. And so they're usually not open to testing one therapy for two different clinical diseases that have a same biological mechanism, but there's some push in doing that. And so industry is interested, obviously, if they have a anti-tau therapy for a rare disease, they want to know, we would want to test it in PSP and CBD in parallel. And so there is a kind of renewed movement in trying to advocate for that. So this is not an answer for what you could do now, but there's a term for it. I forgot if it's called basket trials, like multiple disease with one therapy. It's used in oncology for cancer treatment. It's used in other fields, so we're pushing for that. And this is something where there's also a group at UCSF who's going to start a CBD clinical trial just at UCSF. So it's not going to be a large one, but there's a bit more of an acceleration also to focus on CBD. Just wanted to add that consideration.
Really good to hear.
Hi, Dr. Spears. I have a hard question for you. So it's very encouraging to hear the progress that's being made in research. What concerns do researchers have about the changes in federal funding for research, and how do you think that'll affect the timeline?
Yeah, and that's what Christoph may actually add to as well, given that involvement. But the way I look at it is, especially right now, our neuroimaging, for instance, we have neuroimaging trials, PET imaging trials, and MRI at the University of Michigan towards PSP in these conditions. There hasn't been a lot of change in those yet. And that is definitely the underlined, bold, italicized. That's the really the important word there, because all funding that's been promised, because most research trials, most clinical trials are thought of and funded years. It takes years in advance to get that going. And so the rug hasn't been pulled out. The financial rug hasn't been pulled out. But I think the worry of everybody in science, everybody who does research for these conditions and similar, who do rely and do get a lot of federal funding to sponsor, to help fund that research, is the future. Kind of where's that going to go? And that's where we lean on folks like Christoph, and we lean on those connections. We lean on folks who have had previous roles in the government, with the representative for Virginia, Wexner. We lean on all those folks to still represent us and say, hey, you can't pull this funding out. We need it. We can't let this thing slow and all that momentum slow. Got to keep building upon it. So in short, right now, haven't seen a lot of changes, but the future, I think, is undecided. So that's where being vocal, that's where being active, that's where sending those letters, sending those emails, giving those calls to local politicians, and being an advocate for yourself and your loved ones is really important.
Add to that, and Jessica can also speak to it. So when I talked to the leader of the clinical trial platform, I asked them the same question, right? It's an NIH-supported project. It's a $78 million grant, so also shows you the cost of doing such a thing. And they're saying, well, right now we're moving forward, right? So we got a big enough chunk of the money to get started. We got private sector interested. So a lot of neurologists are saying, okay, we have the work to do. We focus on that, right? So in a way, that is moving forward. We are ramping up our advocacy and an education effort. So and Jessica is leading that with her team. We also retained a law firm to help us do it in DC. It's complicated, but it's also an opportunity for us to bring up the fact that neurodegeneration is a bipartisan issue, right? There's no politics in trying to slow down or eventually stop, Alzheimer, Parkinson, PSP, CBD, and MSA. And we've seen that in the past, and it was pretty polarized in the past. But issues around advancing science around brain health and neurodegeneration has been it's easier to make it a bipartisan issue. So we hope that if things get cut, and then I don't want any of the science funding to be cut because I'm a scientist myself, but that these critical topics like brain health and brain diseases will be prioritized because they're relevant to everybody, to civilians, to the military, to different age group and different socioeconomical strata. So we're trying to do our best to build a bit more advocacy around it and watching how it's developing. We're in touch with many other bigger foundations that are thinking about that as well. So, so far, we're moving forward, and none of the work that we've done or are planning on doing has been interrupted. So it's a bit of a, it's scary, but we're moving forward.
I have another question. There's one biopsy. I have MSA, and I had the skin biopsy, and an expert said that negative results, which I had don't mean anything. I'm wondering what you think about that skin biopsy for MSA patients.
Yeah, and so my thoughts on the skin biopsy for MSA patients are that it's still early in it, I'll say. I think it's a tool, especially when we're trying to validate, are we dealing with a Parkinson's disease like MSA? Can we use it and can we leverage it to differentiate Parkinson's disease from MSA? Some research says yes. Other research says, well, maybe. And so I'm just waiting a little bit. I'm the one who does the biopsies at the University of Michigan, so I'm doing the biopsies, but I'm also making sure to educate patients and say, this is pretty new. It may help guide us and tell us that we're heading in that direction, or that this is indeed MSA versus Parkinson's, but I wouldn't bet the house on it yet. Maybe a coffee, but not the house. But I think it may very well be a very valuable tool, and when a little bit more research comes out to say that, yes, this thing is 100% or 98%, then that's when I'll put the chips in. But that skin biopsy can help differentiate those really tough cases, especially those tough cases where someone looks like they may have PSP or MSA. And how can we get the mud out of the water? How can we clarify? That's a really good use for it. Or when it may not be MSA, but a condition that mimics MSA. Another really good use of that biopsy even right now. So we are using it at an increased rate in that patient population. And it's a very small, she can attest, very small 3 samples for that skin biopsy.
I have a question, Chauncey, if no one else does at the moment.
Yes.
I'm over here.
Oh, hey.
You mentioned briefly that some people only have 30 minutes, maybe an hour with an appointment. Do you have any recommendations on how they can best prepare for those 30 to 60 minutes?
Yeah, a really good question. So how do you best prepare for that visit is a couple things. If it's the first visit, bring your CD. Bring a CD if you've had any pictures of your brain done, dopamine scans or DAT scans, MRIs. Bring a CD or even mail them in ahead of time. But also have a copy on you because things can get lost. And the other thing is before the visit, it's very important to prioritize. Prioritize what means the most. What are the most burning questions you have at that visit? What are the most burning symptoms you have at that visit that you say, hey, I've got a lot going on, because it's not uncommon to have a lot going on with these conditions. But these are the 1, 2, 3. If I knock these things out, these are the things I have to knock out this visit. So help your doctors prioritize that visit, because it's very easy to get lost in all the things that can be going on or presented at one visit. And then reach out to them. A lot of healthcare systems use patient portals where you can send your doctor messages. Itemize that list. I have a number of patients who, former accountants, former secretaries, former very organized, a lot of engineers, and they will send me a PDF of all the things they want to talk about with different grading systems on what's most important to them the week before the visit. I usually read them, but it's really nice to fall back on. And even if I can't get to everything during that visit, I have that to say, all right, well, hey, as soon as I have a minute, let me take a look, and I'll reach back out to you to make sure we cross these other things off that list. I don't want to leave a stone unturned. Oh, yes.
I have evidence, of course, that my brain loss on my right side of the brain is increasing at rates higher than what I expected. And in talking to my husband, I was like, well, so what's going to happen? Is it disappear completely? When is it going to stop? Or does it stop at some point when the illness is like, I don't know, I have had it for 7 years. I mean, let's say, if lucky, I can get to 15. But I thought about the brain itself, you know. I get neuro readers every 2 years. And so that's when I can really see. I'm a chemistry science by nature, so I need to see, I need to understand what my brain is doing. And I had that question actually for my doctor that I'm gonna see in a couple of months. But if you can talk about it, what happens with the brain at some point?
Yeah, it's still there. Maybe a little smaller, but it's still there. And so to me, that brings up the really important point. When we talk about scans, especially, do we follow a scan every year if you have corticobasal or PSP or MSA? And it just depends on the person. If that helps you, then sure. It's not usually that big a deal to get a scan every year. But one thing that's very important to know is that an MRI, for instance, it shows us what's there. It doesn't show us how well it's working or not working. And so those two things can be a mismatch. I see patients in my clinic who have a lot of troubles with PSP, a lot of troubles with corticobasal, and their brain looks immaculate. The MRI doesn't really give credit to how they're affected by their condition. So you can have a good-looking MRI but still be affected a lot by a condition, especially these microscopic neurodegenerative conditions like corticobasal. You can have I've also seen some pretty bad-looking brains, but people are functioning really, really well. And so it works both ways. So again, brain won't disappear in full. That balance of function and structure, how is what's there is working, is that combination of really the different type of testing they do. I'm sure all of us are probably tired already of tapping our fingers and opening and closing our hands. But those things, and also the questions about how you're functioning day in and day out with your illness, are actually more important to me than usually the picture.
Hi, is there any reason why there are certain good days and then there are certain like really bad days?
Yeah, so good days, bad days. So that's something a common theme we see across all neurodegenerative conditions. And so Parkinson's, PSP, corticobasal, MSA, Alzheimer's, ALS, we see good days, bad days across all of them. And the way I always liken it is that we all, even if you don't have any of these conditions, we all have good days, bad days. Some days when we're really cooking, getting a lot done, the other days when we have to, not as productive day. But that's amplified. That's amplified in these conditions where you're not running on a full tank of gas. Okay? We know that these conditions affect you not in just one area, but across the entire brain, most of them, at least to some extent. And so there's a lot of things that can contribute to that. Those bad days, if you're just too busy, you got too much going on, it's a really socially engaging day. If you didn't get a great night's sleep, if you have things like sleep apnea, any straw that adds up can break the camel's back, especially if you have these conditions. So what I often say is we all have good days, bad days, they're just amplified in these conditions. Your doctor will do everything they can to look for the things that can definitely add to that, add weight to those days and make those bad days more impactful. But it's a common thing. I think you hit the nail on the head. It's a common thing we see in these conditions.
All right. Thank you, Dr. Spears. That was fantastic. We now have some chair yoga with Jess. So I'll pass it over to her. We really appreciate you, Dr. Spears.